Welcome to the Deep Dive, the show where we cut through the noise to get you informed fast. Okay, picture this. Something like nearly a quarter, maybe even a third, of all deaths from injury, right, globally, could actually be prevented.
That's a huge number.
It really is. Just a staggering number of lives kind of hanging in the balance. So today we're taking a deep dive into the initial management of the trauma patient.
Right.
It's all about understanding this core systematic approach that emergency teams use, to rapidly assess and manage injuries.
Yeah, the system is key.
Exactly. Our mission today is to uncover not just the what, but really the why behind these crucial life-saving decisions.
It really is about precision, isn't it? And organization. Almost cheating death in those first few moments. We're going to break down the logic, the thinking that helped save lives right then and there.
When we talk trauma, there's this really important concept, the trimodal distribution of trauma deaths. What exactly does that mean, and why is it so critical for, medical teams to understand?
So yeah, trimodal. It basically describes 3 peaks, right? 3 main times when deaths occur after injury. The first peak happens almost instantly, like within seconds or minutes.
Okay.
These are often catastrophic injuries. Think massive brain damage, torn aorta, often, sadly, unsalvageable.
Right.
Then you get the second peak. This happens within the first few hours after the injury.
Ah, the golden hour people talk about.
That's the one. It's such a key insight because this is the period where rapid assessment, rapid management, it's absolutely crucial.
Makes sense.
Deaths here are typically from, say, a serious head injury or just uncontrolled bleeding, hemorrhage.
And that golden hour, that's where these organized trauma systems can make a huge difference, right?
Precisely. Yeah, the data suggests these systematic approaches, this organization, could cut trauma deaths by, well, at least 10%, maybe more.
Wow.
It just highlights how important it is to focus intensely on that specific, pretty narrow window of time. Strategic, really.
So, okay, in these really high-stakes situations, how do the medical pros even begin to sort out the injuries? How do they know where to put their focus first?
Well, injuries generally get divided into, let's say, 3 main categories. You've got your severe injuries. These are the immediately life-threatening ones, like blocked airway, not being able to breathe properly, massive bleeding, that sort of thing. Now, interestingly, these only make up maybe 5% of all patient injuries.
Only 5%.
Yeah, but here's the kicker. They account for over half of all trauma deaths.
Over 50%. That's disproportionate.
Hugely. Then you have urgent injuries. That's maybe 10–15% of cases. These need attention, need intervention, but they're not an immediate threat to life in the next few minutes.
Okay.
And finally, you have non-urgent injuries. That's the bulk, maybe 80% of all injuries. They need to be managed, absolutely, but they aren't life-threatening right now. The primary goal always is to find and fix those severe life-threatening injuries first. Fast.
Right, find the biggest fires first. And I know scoring systems were developed to help predict outcomes, add some objectivity maybe. What's one of the earliest ones?
Yeah, adding objectivity is a good way to put it. One of the real foundational ones is the Glasgow Coma Scale, the GCS, developed way back in '74.
GCS, right.
It quantifies head injury severity based on 3 things you can observe: eye-opening, the best motor response you can get, and the best verbal response.
Okay.
Scores range from 3, which is, deeply unresponsive, up to 15, which is normal, a GCS of 9 or less. That's a pretty strong indicator of, unfortunately, higher mortality rates. The real insight here, I think, is how these scales give everyone a common language for severity. Allows teams to triage, make these incredibly tough decisions with a level of speed and hopefully accuracy that just wasn't possible decades ago.
So we just talked GCS. How did that thinking evolve? What other vital signs got folded in to create tools like the revised trauma score to get a more complete picture?
All right, so the GCS was and is incredibly useful, but it really only looked at the head injury aspect. It didn't capture the whole physiological state of the patient.
Gotcha.
So the original trauma score was developed and then later refined into the revised trauma score, or RTS. That was in 1989.
Okay, RTS. What does that add?
The RTS combines the GCS score with 2 other key vital signs: respiratory rate, how fast they're breathing, and systolic blood pressure.
Ah.
The scores for RTS range from 0 to 12, but here, lower scores mean worse injury.
Opposite of GCS, then.
Exactly. So, for example, an RTS score of 8, that suggests something like a 33% chance of mortality.
Wow.
These aren't just numbers, right? They're an attempt, a really important attempt to quantify the sheer chaos of a major trauma situation, give you a baseline.
And then for patients who have multiple injuries, which must be common, there's the Injury Severity Score, ISS. That one sounds a bit more involved.
It is, yeah, a bit more complex. The ISS is designed specifically to capture the overall severity when you've got injuries in multiple parts of the body.
How does it work?
It categorizes injuries by organ system, respiratory, CNS, cardiovascular, musculoskeletal, etc., and then grades the severity within each system from 1, which is minor, up to 6, which is considered fatal or unsurvivable.
Okay.
To get the final ISS score, you take the 3 highest scores from different body regions, square each of those scores, and then add them up.
Square them. Wow.
Yeah, squaring them gives more weight to the more severe injuries. The highest possible score is 75, technically, if you have 3 regions scored as 5, critical. A score of 6 in any region makes the ISS automatically 75, implying unsurvivability, though practically the maximum calculated score is often cited higher, but 75 is the functional max for survival prediction.
And higher score means worse outcome.
Definitely. The data clearly shows mortality rates climb pretty steeply with a higher ISS. And importantly, age is a big factor too. The same ISS score is generally worse for an older patient.
So beyond these numbers, these scores, it's also really important to look at how the injury happened, the mechanism of injury, and the anatomic factors, right? What kind of clues can those give you?
Oh, absolutely critical clues. These can often tip you off to potentially serious injuries before the vital signs even start to change dramatically.
Like what kind of mechanisms?
Well, mechanism of injury factors include things like evidence of a really high-energy collision, a car crash with major damage, a fall from a significant height, say over 6 meters, about 20 feet.
Okay.
Or being in a dangerous environment like a fire or explosion. With car accidents specifically, details matter. Was the patient trapped for a long time, like over 20 minutes? Was there major damage to the passenger compartment? Were they thrown from the vehicle? Did the car roll over? Or, tragically, did someone else in the same car die? All those are big red flags.
And the anatomic factors, what are those?
Those refer to the specific types of injuries observed that strongly suggest life-threatening conditions. Things like penetrating trauma stabbings, gunshot wounds to critical areas, head, neck, torso, groin, even the thigh, because of the major artery there.
Right.
A flail chest, which we'll probably talk more about, major burns, amputations, obviously, having 2 or more major long bone fractures, like both femurs, or any signs of paralysis.
Okay.
And it's really vital to remember those concurrent factors, too. Age is a big one. Being very young, under 5, or older, over 55, generally means a worse prognosis.
Right.
And having pre-existing conditions like heart disease or COPD can significantly impact how well someone tolerates major trauma, even if the injuries themselves seem only moderately severe on paper.
So with all this information flying around, vital signs, scores, mechanism, anatomy, how do medical teams actually systematize the initial response? It sounds incredibly high pressure.
It absolutely is. And that's exactly where the Advanced Trauma Life Support System, ATLS, comes into play.
ATLS.
Yeah. It provides a really structured, orderly, schematic way to approach it. It breaks down that initial assessment and management into clear phases. First, a rapid primary evaluation, find the immediate killers. Simultaneous resuscitation, bringing vital functions back online. Then a more detailed secondary assessment, head to toe. And finally, initiating definitive care, getting the patient to surgery or whatever specific treatment they need. That structure is key to making sure nothing critical gets missed in the chaos.
And that brings us right to the core of today's deep dive, that primary survey, often called the ABCSDE of life-saving. What's the big picture goal of this initial survey?
The whole purpose is speed and focus. Quickly identify and then reverse conditions that will kill the patient in minutes if not addressed. And what's really crucial here is that assessment and intervention, the fixing, often happen at the same time.
So you don't wait to finish the whole check before you act.
No way. If you find a blocked airway, you fix it right then. It's about acting fast, often using well-honed instincts backed by rigorous training.
Okay, so starting with airway maintenance, but with cervical spine control. What's the absolute top priority here?
A patent airway. Simple as that. If the patient can't get air in and out, nothing else you do is going to matter much.
What usually blocks it?
Oh, lots of things in trauma. Bleeding, from facial injuries into the mouth or throat. Aspiration, maybe they vomited or there's debris. Facial fractures themselves can disrupt the anatomy. Direct trauma to the airway, like the larynx or trachea. Regurgitation, or sometimes, especially if they're unconscious, it's simply the tongue falling back and blocking the pharynx.
So what are the immediate moves to open that airway?
First things are simple maneuvers. a chin lift, or a jaw thrust. These physically lift the tongue and soft tissues away from the back of the throat.
Which one's better?
The jaw thrust is generally considered safer if you even remotely suspect a neck injury because it involves less neck movement.
Okay.
And then, yeah, you got to quickly clear out anything obvious, blood, vomit, broken teeth, maybe using your fingers, hopefully gloved, or suction if you have it ready.
And this brings us to that crucial second part of cervical spine control. You mentioned assuming a neck injury for any trauma above the collarbones or if someone's not fully conscious. Why is that assumption so incredibly critical? Does it cause problems in practice?
It's critical because moving an unstable neck fracture, even slightly, can have devastating consequences. It can literally turn an injury without neurological damage into permanent paralysis.
Wow.
So yeah, maintaining that cervical spine in a neutral position, using a rigid backboard, straps or bindings, and head immobilizers on the sides, it's absolutely essential from the get-go.
Do those neck collars help much?
They help, yes, but it's important to understand their limits. Soft collars. Almost useless for real stabilization. Even the semi-rigid ones people see paramedics use, they offer maybe 50% stabilization at best.
Only 50%.
Yeah. Which means even with a collar on, you still need that full system, the board, the blocks, the straps, extreme care, with any movement until a neck injury can be definitively ruled out, usually later with imaging. And yes, it's a huge practical challenge, trying to maintain that perfect stillness while doing everything else in a potentially chaotic scene.
Okay, moving to B, for breathing and adequate ventilation, what's the key thing to assess here, beyond just seeing if air is moving in and out?
Right. It's definitely not enough just to feel or listen for some air movement at the nose and mouth. You need to confirm true, adequate ventilation. Are they taking deep enough breaths? Is the rate normal, too fast, too slow? Shallow breathing or really abnormal rates usually mean poor ventilation, even if some air seems to be exchanging. Depth and quality matter just as much as the presence of breathing.
And in terms of breathing, what are those absolute immediate life threats that need fixing right now?
Okay, yeah, there are a few critical ones. First is an open pneumothorax. People often call it a sucking chest wound.
What is that exactly?
There's basically a hole in the chest wall big enough that air gets sucked directly into the pleural space, the space around the lung, with each breath, instead of, or in addition to going down the trachea. You can often hear it.
Okay, and the fix?
The immediate fix is to cover that hole with a sterile, occlusive dressing, something airtight. But, and this is really important, you only tape it down on 3 sides.
3 sides, why not all 4?
Because the untaped side acts like a one-way valve. It lets trapped air escape from the chest cavity when the patient breathes out, but prevents more air from getting sucked in when they breathe in. If you taped all 4 sides, you could trap air inside and actually cause the next problem.
Which is?
A tension pneumothorax.
Ah, okay. That sounds tense. What happens there?
It's incredibly dangerous. Life-threatening within minutes. A tension pneumothorax happens when air gets into that pleural space, usually from an injured lung on inspiration, but it can't get out on expiration.
It builds up.
Exactly. Pressure builds and builds. The lung on that side collapses completely. Then the increasing pressure pushes the entire mediastinum, the heart, the great vessels, the trachea, over to the opposite side.
Oh, wow.
This squashes the good lung, and critically, it kinks or compresses the vena cava, the big vein returning blood to the heart. So the heart can't fill properly, cardiac output plummets,
Leading to?
rapid hypoxia, low oxygen, acidosis, blood becomes a fire, and profound shock. It's a spiral downwards fast.
What are the signs? What would you look for?
The patient becomes acutely ill, very suddenly. Severe respiratory distress, gasping for air. You listen to the chest, and breath sounds are decreased or totally absent on the affected side.
Okay.
If you tap on that side of the chest, it sounds hyper-resonant, kind of like a drum, because of the trapped air. Neck veins might be distended because the blood can't get back to the heart easily. And maybe the most classic sign, though sometimes late or hard to see, is tracheal deviation. The windpipe is visibly pushed away from the injured side.
So immediate treatment is absolutely vital. What is it?
Life-saving. You don't wait for an x-ray. You have to immediately decompress the chest. That means inserting a large bore needle, like a 14 or 16 gauge, into a specific spot in the chest wall, usually the second intercostal space in the midclavicular line.
Just stick a needle in.
In the right place, yes. You'll often hear a hiss of escaping air. This instantly relieves the pressure, converts the tension pneumothorax back into a simple pneumothorax, which buys you time. Then you follow up by placing a proper chest tube to drain the air continuously.
Okay, got it. Needle first, then chest tube. What's another immediate breathing threat?
A massive hemothorax.
Hemo meaning blood.
Right. This is a large collection of blood in the pleural cavity, again, the space around the lung. Often happens with penetrating injuries like stabbings or gunshot wounds, or sometimes severe blunt trauma that tears major blood vessels inside the chest, like the aorta or vessels near the lung root.
And the danger is blood loss.
Exactly. It can rapidly lead to hypovolemic shock from blood loss because a lot of blood can accumulate in the chest cavity quickly. You'd suspect it if the patient is in shock, has reduced breath sounds on one side, and you tap on that side, it sounds dull, not resonant, because it's full of fluid, blood.
How do you manage that one?
Two main things simultaneously. First, aggressively restore blood volume, large IVs, pouring in fluids and getting blood products ready or infusing. Second, you need to drain that blood out of the chest cavity. This is done with a large chest tube, usually 36 or 40 French, inserted a bit lower and more to the side than for a pneumothorax, typically 5th or 6th intercostal space, mid-axillary line.
And sometimes surgery is needed.
Yes. If there's a massive amount of blood drained initially, say more than 1,500 milliliters right away, or if the bleeding continues at a high rate, like over 200 milliliters per hour for several hours, that usually indicates ongoing active bleeding that needs surgical exploration and open thoracotomy to find and fix the source.
Okay. And then there's flail chest. That sounds painful and serious.
It definitely is. A flail chest happens when you have multiple adjacent ribs, usually 3 or more, fractured in at least 2 places each.
2 places. Why is that important?
Because it creates a segment of the chest wall that's no longer structurally connected to the rest of the rib cage. It becomes unstable, floating.
And what does that segment do when the person breathes?
It moves paradoxically. So when the patient breathes in, the negative pressure in the chest sucks that unstable segment inward while the rest of the chest expands. When they breathe out, the segment pushes outward. It's the opposite of normal chest wall motion.
That must really impair breathing.
It does, but what's truly insightful, and maybe counterintuitive, is that the main reason these patients get hypoxic and have complications often isn't just the mechanics of the flail segment itself. It's the damage to the lung tissue underneath the fractures, the pulmonary contusion. The lung bruising we mentioned. Exactly. That bruising causes swelling and bleeding into the lung tissue. It often isn't obvious right away on the first x-ray, but tends to worsen significantly over the first 24 to 72 hours. That's the real driver of mortality, which range anywhere from 12% up to 50% in severe cases.
So how do you manage flail chest? It sounds like you'd need to brace it externally somehow.
You know, that's what you might think, but external bracing isn't really the standard approach. The focus is actually more on managing the consequences. First, pain control is huge. Effective pain relief allows the patient to breathe deeper and cough, which helps prevent pneumonia. Nerve blocks, like intercostal blocks, are often preferred over heavy narcotics, which can suppress breathing.
Makes sense.
Then supplemental oxygen is crucial, and often the key is ventilation control. Many of these patients need mechanical ventilation, often with a volume-cycled respirator, using settings like PEEP-positive end expiratory pressure and IMV intermittent mandatory ventilation.
How does that help the flail part?
It acts as an internal splint. The positive pressure from the ventilator helps keep the alveoli, the tiny air sacs in the bruised lung, open and prevents them from collapsing. This improves oxygen exchange, and by stabilizing the lung from the inside, it indirectly helps stabilize that flail segment too.
Interesting. So after you've secured the airway, addressed these immediate breathing threats, oxygenation comes next. I guess just giving supplemental oxygen is standard.
Absolutely, right away. Putting a patient on 100% oxygen via a mask can massively increase the amount of oxygen available in their lungs, maybe by as much as 400% compared to room air.
Wow.
But, and this is a critical link to the next step, the most important way oxygen actually gets delivered to the tissues and organs is via hemoglobin, which is inside the red blood cells. So even if the lungs are full of oxygen, if you don't have enough blood volume, enough red blood cells circulating, that oxygen isn't going to get where it needs to go, which leads us directly to
C circulation with control of hemorrhage. And you said the most common cause of shock and trauma is hypovolemia, right, from blood loss, either external or internal. So assessing perfusion, how well blood is flowing, is key. But you mentioned blood pressure can be tricky.
Yeah, it's a really interesting and important point. Blood pressure can be a surprisingly late sign of shock, especially in young, healthy people.
Why is that?
Compensatory mechanisms. The body is amazing at trying to maintain blood flow to vital organs. It clamps down peripheral blood vessels, increases the heart rate. These things can keep the systolic blood pressure looking relatively normal, even when someone has lost, say, 15% or even 20% of their total blood volume.
So you could be fooled if you only look at the BP number.
Exactly. The drop, when it comes, can be sudden and profound. That's why we rely heavily on other, more sensitive, earlier indicators of poor perfusion.
Okay, so if blood pressure isn't always reliable early on, what is the most reliable sign that tissues aren't getting enough blood?
Skin perfusion. It's usually the first place the body shuts down blood flow to conserve it for the core organs.
What do you look for?
You look for cool, damp, pale skin. Especially check areas further from the core, like the feet or even the kneecaps. Compare their temperature to the core temperature. And checking capillary refill time.
How do you do that?
You press firmly on a nail bed or the skin over the kneecap or forehead, make it blanch white, and then see how quickly the normal pink color returns when you release the pressure. It should snap back in less than 2 seconds. Longer than that is abnormal and suggests poor perfusion.
Okay, skin. What else? Pulse rate.
Pulse rate is generally much more sensitive to early blood loss than blood pressure. The heart beats faster to try and compensate for the lower volume being pumped with each beat.
So a fast pulse is a warning sign.
Definitely. A heart rate over 120 beats per minute in an adult. That often signals significant blood loss and needs immediate investigation and action. Also, just checking for the presence of the most distal, palpable pulse, like the radial pulse at the wrist, can give you a very rough, quick estimate of systolic pressure. If you can feel a radial pulse, the systolic is likely at least 80 mmHg. If you can only feel ephemeral or carotid, it's likely lower.
Urinary output also tells you something about circulation, right?
Yes, absolutely. Urine output is a really good indicator of how well the kidneys are being perfused, which reflects overall systemic perfusion. Healthy kidneys getting enough blood flow will make adequate urine.
So you monitor that how?
Usually by inserting a Foley catheter into the bladder to continuously measure urine output. The target is generally at least 0.5 milliliters per kilogram of body weight per hour for an adult. Less than that suggests inadequate perfusion.
But you mentioned a caution with inserting that catheter.
Yes, absolutely critical. Before you insert a Foley, you must check for signs of urethral injury, especially in males with pelvic trauma. Look for blood at the tip of the penis, the urethral meatus, bruising of the scrotum, scrotal hematoma, or if, on a rectal exam, the prostate gland feels like it's floating high up or isn't palpable.
Why is that so important?
Because if the urethra is torn, trying to force a catheter through can turn an incomplete tear into a complete transection, causing much more damage and long-term problems. If you suspect urethral injury, you need to get a special X-ray called a retrograde urethrogram before attempting catheterization.
Got it. Check first. What about mental status? How does that relate to circulation?
Changes in mental status like agitation, confusion, combativeness, or eventually lethargy and unresponsiveness are usually signs of pretty severe, often pre-terminal stages of shock or fluid loss.
Why so late?
Because the brain is prioritized. Cerebral blood flow is usually maintained relatively well until the systolic blood pressure drops really low, often below 60 mmHg. So if you're seeing mental status changes due to shock, it's very serious.
But other things can affect mental status, too.
Oh, absolutely. Yeah. Head injury itself is a major one. Also, alcohol or drug intoxication is incredibly common in trauma patients and can make assessing the mental status due to shock very difficult.
Yeah.
You always have to rule out an intracranial injury first in someone with altered mental status after trauma.
What about looking at the neck veins? What can they tell you?
They can give you a clue about the volume status and potential chest problems. If the neck veins are flat, even when the patient is lying down, it usually suggests hypovolemia, not enough blood volume.
And if they're distended, sticking out?
Distended neck veins suggest that blood is having trouble getting back to the heart. That could be due to a tension pneumothorax, which we talked about, pressure in the chest is impeding venous return, or it could be due to cardiac dysfunction, specifically cardiac tamponade.
Cardiac tamponade again. How does that cause circulatory failure, and how might it look different from a tension pneumothorax, if at all?
So cardiac tamponade is when blood fills the pericardial sac, the space right around the heart muscle. As that sac fills with blood, it squeezes the heart and prevents the chambers, especially the right ventricle, from filling properly during diastole.
So the heart can't pump what it doesn't receive?
Exactly. Less blood in, less blood out. Cardiac output drops, leading to shock and circulatory collapse. Like tension pneumo, it can cause distended neck veins and low blood pressure. The classic Beck's triad, low BP, distended neck veins, and muffled heart sounds is taught. But honestly, you rarely see all three clearly in an acute trauma setting. The heart sounds might be hard to hear anyway.
So distinguishing them clinically can be tough.
It can be very tough sometimes, especially initially. Both cause obstructive shock. Fast ultrasound exam can be very helpful here to see fluid around the heart.
And the management for tamponade.
If it's causing hemodynamic compromise, the immediate treatment is pericardiocentesis, inserting a needle into the pericardial sac, usually via the subxiphoid approach, just below the sternum, to drain the blood and relieve the pressure. This is often a temporizing measure, buying time to get the patient to the operating room for a thoracotomy or sternotomy to definitively repair the source of bleeding.
Okay, so controlling the bleeding itself is paramount in C. For external bleeding, like from a wound, what's the approach?
Direct pressure. Firm direct pressure right on the bleeding site is the first and most important step. Elevating the injured extremity, if possible, can also help reduce pressure and bleeding.
What about tourniquets?
Tourniquets have made a comeback, especially in military settings and now more in civilian EMS, for severe, life-threatening limb hemorrhage that can't be controlled by direct pressure. But they have risks, like nerve damage and tissue death, so they're reserved for specific situations and require proper training. For most wounds, direct pressure is the mainstay.
And you mentioned not removing dressings.
Right. If the first dressing becomes soaked with blood, don't take it off. Just add more dressings on top and keep applying pressure. Removing the initial dressing can dislodge any clot that's starting to form and make the bleeding worse. Scalp wounds, by the way, can bleed an astonishing amount because the scalp is so vascular. They often need quick closure with sutures or staples to get control.
And internal bleeding. Where are the big places blood can hide inside the body?
The major internal compartments where life-threatening hemorrhage can occur are the chest cavity, hemothorax, the abdominal cavity, hemoperitoneum, the retroperitoneum, that's the space behind the abdominal lining where the kidneys, pancreas, and major blood vessels are, and into the tissues around major fractures, especially in the extremities.
You gave some startling numbers for fracture blood loss earlier.
Yeah, it's often really underestimated how much blood can be lost internally from fractures. A pelvic fracture, especially an unstable one, can easily lead to 1 to 5 liters of blood loss into the pelvic space and a retroperitoneum.
5 liters. That's basically someone's entire blood volume.
It can be, yes. A femur fracture can bleed 1 to 4 liters into the thigh. Even a humerus fracture in the upper arm can lose half a liter to a liter. Just to give you a visual, a hematoma, a collection of blood under the skin about the size of your fist or a large apple that represents roughly 500 milliliters, half a liter of blood loss right there.
That's a lot of hidden blood loss. Are there different stages or classes of hypovolemic shock that help guide how aggressively you treat?
Yes, the source material breaks it down into 4 classes, based roughly on the percentage of blood volume lost and the physiological response you see.
Can you walk us through those quickly?
Sure. Class 1 is up to about 15% blood volume loss, maybe 750 milliliters in an average adult. Here, the body's compensating well. Heart rate might be slightly up, but blood pressure, breathing rate, urine output are usually normal, maybe just a little anxiety.
Okay, mild. Class 2.
Class 2 is 15–30% loss, say 750 to 1,500 milliliters. Now you start seeing more obvious signs. Heart rate is definitely up, over 100. Respiratory rate increases. The pulse pressure, the difference between systolic and diastolic BP starts to narrow. Skin might feel cool, capillary refill might be slightly delayed, urine output starts to drop, they might be more anxious.
Getting more serious. Class 3.
Class 3 is 30–40% loss, maybe 1,500 to 2,000 milliliters, and now you're in clear shock. Heart rate is high, usually over 120. Systolic blood pressure drops. Respiratory rate is rapid. Skin is cool, clammy, definitely delayed capillary refill. Urine output is low, maybe less than 30 milliliters. Mental status changes become apparent, anxiety, confusion. This patient needs blood.
And Class
4 is hemorrhage of more than 40% of blood volume, over 2,000 milliliters. This is immediately life-threatening. Heart rate is extremely high, over 140, or sometimes can become bradycardic terminally. Blood pressure is very low. Pulse pressure is very narrow or undetectable. Breathing is very rapid and shallow or slowing down. Skin is cold, pale, mottled. Urine output is negligible. Mental status is confused, lethargic, or unresponsive. This is profound shock, bordering on irreversible if not treated immediately and aggressively.
So fluid resuscitation is obviously critical. What's the very first step? Where do you put the IVs?
The standard initial step is to establish intravenous access quickly. The goal is 2 large bore IV catheters. We're talking 14 or 16 gauge, maybe 18 at the smallest.
Why 2 and why large?
2 lines give you redundancy and double the potential infusion rate. Large bore is crucial because the flow rate of fluid through a catheter is dramatically affected by its radius. Wider is much, much faster. You want to be able to give fluids rapidly if needed.
Where do you usually put them? Peripheral veins? Central lines?
Preferably peripheral veins, usually in the antecubital fossa, the crook of the elbow, or maybe large veins in the forearm. Peripheral VIDs are generally much quicker and easier to place in an emergency setting than central lines, and large bore peripheral IVs can actually allow for higher flow rates than standard central line ports. Central lines might be needed later, but for initial resuscitation, large peripheral access is usually the priority.
Okay, access established. What fluid do you give first?
The initial fluid resuscitation is typically done with an isotonic crystalloid solution. The most common ones are lactated ringers, LR solution, or normal saline, 0.9% sodium chloride.
How much do you give?
The standard initial bolus for an adult is 1 to 2 liters, given rapidly, often wide open, maybe over 10-15 minutes. For pediatric patients, the initial bolus is typically 20 millimolars per kilogram of body weight.
What about colloid solutions, like albumin? There used to be debate about those.
There was, yeah. The crystalloid versus colloid debate went on for years. Crystalloids are cheaper and readily available. Colloids theoretically stay in the bloodstream longer. However, multiple large studies and meta-analyses have generally not shown a benefit for colloids in trauma resuscitation, and some have even suggested a trend towards increased mortality, possibly due to effects on coagulation or kidney function. So, crystalloids remain the standard initial fluid.
Okay, crystalloids first. But if the patient is still in shock after that initial bolus, or if they were in severe shock to begin with, when do you start thinking about giving blood?
You start thinking about blood very early if the patient presents in class 3 or class 4 shock, or if they don't respond adequately to the initial crystalloid bolus. Blood products are essential to restore oxygen-carrying capacity and address coagulopathy.
What kind of blood? Does it have to be perfectly matched?
Ideally, yes. Fully cross-matched blood is the safest, as it checks for compatibility against many potential antibodies. But that process takes time, often 30 minutes or more.
Too long and severe bleeding?
Often, yes. The next best option is type-specific blood. If you know the patient's blood type, like a positive, O negative, etc., you can give them ABO and RH compatible blood. This is much faster, maybe 5 to 15 minutes to prepare.
And if it's life or death bleeding right now?
Then you reach for O negative red blood cells. O negative is the universal donor for red cells, meaning it can generally be given to anyone regardless of their blood type in an emergency. However, O negative blood is often in short supply, so it's typically reserved for exsanguinating hemorrhage and usually limited initially, maybe up to 4 units, while type-specific or cross-matched blood is prepared.
What's the goal when you're giving blood? How much hemoglobin are you aiming for?
The traditional target was often a hemoglobin level of 10 GDL. More recently, transfusion triggers have become a bit more nuanced, often aiming for a target closer to 7 or 8 GDL in many patients once they're stabilized, to conserve blood products. But in active, massive hemorrhage, the goal is simply to restore circulating volume and oxygen-carrying capacity to keep the patient alive, often guided by their physiological response rather than just a specific number.
What about other blood components like plasma and platelets?
Absolutely crucial, especially in massive transfusion situations, which is often defined as replacing the patient's entire blood volume within 24 hours or giving more than 10 units of red cells in 24 hours. When you lose a lot of blood, you don't just lose red cells, you lose plasma, which contains all the clotting factors, and you lose platelets, which are essential for clot formation.
So you need to replace those too?
Yes. Modern massive transfusion protocols, MTPs, emphasize giving red blood cells, fresh frozen plasma, FFP, and platelets in a balanced ratio, often close to 1.1.1 right from the start. This helps prevent or treat the coagulopathy, the inability of the blood to clot properly that often develops in severely bleeding trauma patients.
And body temperature. You mentioned that matters too.
Critically important. Hypothermia, low body temperature, is really common in trauma patients due to exposure, blood loss, and administration of room temperature fluids. And hypothermia itself worsens coagulopathy. The enzymes involved in the clotting cascade don't work well when the body is cold.
The triad of death. Acidosis, hypothermia, coagulopathy.
Exactly. They feed into each other in a vicious cycle. So actively warming the patient is a key part of resuscitation. This means using warm blankets, forced air warming devices like a bear hugger, and warming all intravenous fluids and blood products before infusion. Maintaining normothermia helps the resuscitation efforts work better and improves clotting function.
What about patient positioning? I've heard about putting patients head down, the Trendelenburg position, to improve blood flow to the brain in shock. Is that still done?
It used to be common, but it's generally not recommended anymore, especially in trauma.
Why not?
While it might transiently increase blood pressure by shifting blood from the legs, it can worsen breathing by pushing the abdominal contents up against the diaphragm. It can also potentially increase intracranial pressure if there's a head injury. Elevating the patient's legs slightly while keeping the torso flat is generally preferred if you want to augment venous return without the downsides of Trendelenburg.
Okay, that covers circulation. Now, on to D for disability, the brief neurologic examination. What's the main purpose here in the primary survey?
It's really about getting a quick baseline assessment of the patient's central nervous system function. You want to establish their level of consciousness and check their pupils to quickly identify any major immediate brain problems.
How do you assess level of consciousness quickly?
The simplest, most widely used tool in the primary survey is the AVPU mnemonic. Yeah. A is for alert, are they awake and aware? V is for response to vocal stimuli, do they respond when you talk to them? P is for response to painful. Painful stimuli, do they only respond when you apply a stimulus like a sternal rub or pinching the trapezius? And U is for unresponsive, they don't respond to anything. It gives you a rapid snapshot.
And the pupils, what are you looking for there?
You check the size of the pupils, whether they are equal and how they react to light, constricting when you shine a light in. Unequal pupils, or pupils that are fixed and dilated, don't react to light, can be ominous signs. They might indicate direct brain injury, damage to the optic nerve, or critically increased intracranial pressure compressing the oculomotor nerve.
Are there other common reasons for depressed consciousness besides direct brain injury?
Oh yes. Remember, low oxygen, hypoxia, high carbon dioxide, hypercarbia, and poor blood flow to the brain, hypoperfusion or shock, are all very common causes of altered mental status in trauma patients. You have to address the ABCs first, as restoring oxygenation and circulation might actually improve their neurologic status.
And again, alcohol or drugs can confuse things.
Hugely. Never assume altered mental status is just due to intoxication until you've ruled out serious intracranial pathology, hypoxia, or shock. If the level of consciousness is low, especially if the pupils are abnormal, an immediate CT scan of the head is usually warranted as soon as the patient is stable enough for transport to the scanner.
Okay, finally, E for exposure and environment. This seems straightforward, but why is it so important?
It's absolutely vital because you can easily miss significant injuries if the patient isn't fully undressed. You need to be able to see and examine their entire body surface, front and back. This means carefully log rolling them while maintaining spinal precautions to inspect their back and buttocks. Injuries can hide under clothes, under straps, behind the patient.
So full exposure is necessary, but then there's the environment part.
Exactly. As soon as you've done the visual inspection, you need to cover the patient back up immediately. Trauma rooms are often kept cool. Patients might have been exposed at the scene. They're losing heat from wet clothes or bleeding. Hypothermia sets in incredibly quickly.
And hypothermia is bad, as we discussed.
Very bad. Worsens outcomes significantly. So immediately cover them with warm blankets. Use active warming measures like forced air warmers or warming mattresses. Increase the ambient room temperature if possible. Preventing heat loss is just as critical as finding the injuries.
And throughout this whole ABCDE process, you're constantly reassessing, right? It's not just a one-time check.
Absolutely. Continuous reevaluation is key. Vital signs need to be monitored constantly. The patient's condition can change rapidly. You might fix the airway, but then they develop a tension pneumothorax. You might control external bleeding, but internal bleeding continues. So you're constantly cycling back through the ABCDEs, reassessing and intervening as needed. It's a dynamic process, not a static checklist.
Okay, so once that primary survey is complete, the immediate life threats are addressed and resuscitation is underway, then you move on to the secondary assessment. What's the goal of this phase?
Right. The secondary survey only begins after the primary survey is finished, the ABCDEs are reassessed, and vital functions are stable or stabilizing. The purpose now is a more thorough, systematic, head-to-toe evaluation to identify all injuries, including those that weren't immediately life-threatening but still need treatment.
Still monitoring the ABCs, though.
Constantly. You never stop monitoring the ABCs. A patient who seems stable can deteriorate. So ongoing vigilance is crucial throughout the secondary survey as well.
How does it start? Do you get more history now?
Yes, if possible. If the patient is conscious and able, you try to get a more detailed history. The AMPLE history is a common mnemonic. Allergies, medications, past medical history of pregnancy, last meal, events environment related to the injury. If the patient can't provide history, you try to get it from family, bystanders, or the pre-hospital EMS providers. Then you begin the systematic physical examination.
Head to toe. What specifically are you looking for in the head and skull during this more detailed look?
You're doing a more thorough neurologic exam than just AVPU and pupils. You might do a formal GCS score now, if not already done. You're inspecting and palpating the entire scalp and skull for lacerations, contusions, depressions, or instability that might indicate underlying fractures. You're looking closely at the eyes, ears, nose, and mouth.
Still thinking about brain injury.
Definitely. The major focus in head injury management, beyond the initial stabilization, is preventing secondary brain injury. The primary injury happened at the moment of impact, but secondary injury comes from things like hypoxia, ischemia, lack of blood flow, swelling, edema, and increased intracranial pressure, ICP. These are often preventable or treatable.
You mentioned Cushing's phenomenon earlier, hypertension and bradycardia as a sign of rising ICP. How common is that?
It's a classic sign taught, but it's actually relatively uncommon and usually a late sign, indicating that brain herniation might be imminent. You don't want to wait for Cushing's triad to suspect high ICP. Changes in level of consciousness or pupil changes are earlier warnings.
So CT scans are still the main tool here.
Absolutely. CT of the head is the gold standard diagnostic tool. It's incredibly fast and accurate at identifying intracranial hemorrhage, bleeding inside the skull, epidural, subdural, intracerebral, contusions, bruises on the brain, fractures, and secondary effects like brain swelling or midline shift.
When should the CT be done?
As soon as the patient is hemodynamically stable enough to tolerate the trip to the scanner and the time inside it. For patients with significant head trauma, especially those with altered mental status or focal neurologic deficits, getting that CT scan done promptly after the primary survey and initial resuscitation is critical. Don't wait for neurologic deterioration if you don't have to.
And moving the patient for CT, still need to be careful about the neck.
Oh, yes, always. Remember the high association between significant head facial trauma and cervical spine injuries. The patient must remain fully immobilized with a rigid collar and backboard or equivalent precautions during transport and scanning until the C-spine is definitively cleared, usually by CT scan as well. Often, the head CT and C-spine CT are done at the same time.
What about signs of a basilar skull fracture, that fracture at the base of the skull? What are you looking for during the secondary survey?
You're looking for specific signs like battle sign, that bruising that appears over the mastoid process behind the ear, though it might take hours to develop. Raccoon eyes, or periorbital ecchymosis bruising around both eyes, also can be delayed. Hemotympana blood visible behind the eardrum when you look with an otoscope. Or CSF leakage, clear fluid dripping from the nose, rhinorrhea. Or ear, otorrhea.
And the NG tube caution still applies.
Absolutely. If you suspect a basilar skull fracture, especially involving the cribriform plate at the base of the front of the skull, inserting a nasogastric NG tube is contraindicated because it could potentially pass up through the fracture into the brain. An orogastric OG tube passed through the mouth should be used instead if gastric decompression is needed.
Okay. In terms of neurologic decline with rising ICP, you mentioned a progression earlier. Can you recap that?
Sure. As pressure builds inside the skull, it tends to affect brain structures sequentially. First, the cerebral cortex is affected, leading to changes in consciousness, confusion, agitation. As pressure rises further, it affects the midbrain, which controls pupil function. You might see pupils become sluggish, then fixed and dilated, often starting on one side, the side of the injury. Then the pons is affected, and you might lose corneal reflexes. Finally, the medulla, which controls breathing and basic vital functions, is compromised, leading to respiratory arrest, profound hypotension, and death. This is the process of brain herniation.
And you evaluate motor function, too, specific postures.
Yes. Abnormal motor posturing can indicate severe brain injury. Decorticate posturing, arms flexed, legs extended, suggests damage above the midbrain. Decerebrate posturing, arms and legs extended, suggests damage at the level of the brainstem, which is generally worse. Assessing motor strength, sensation, and reflexes is also part of the more detailed secondary neurologic exam.
And how does the GCS score help guide management decisions at this stage?
The GCS score is crucial for classifying the head injury: mild, GCS 13-15, moderate, GCS 9-12, and severe, GCS 3-8. This classification helps determine the patient's disposition. Can they go home? Do they need admission for observation? Or do they need ICU admission? It also guides decisions about interventions like Intubation, usually for GCS 8 or less, ICP monitoring, and specific treatments to control brain pressure.
Okay, moving down to the chest in the secondary survey, what imaging is important here?
Chest X-ray, often an upright, portable one if possible, is standard. It can show pneumothorax, hemothorax, rib fractures, widening of the mediastinum, air under the diaphragm. But CT scan of the chest provides much more detail and is often done, especially in significant blunt trauma or if the X-ray is suspicious.
You mentioned pulmonary contusion, lung bruising developing later. How do you monitor for that?
Right, pulmonary contusion might not be obvious initially. You need a high index of suspicion, especially with significant chest wall trauma like rib fractures or flail chest. Careful monitoring of oxygen saturation, respiratory rate and effort, and arterial blood gases is key. Serial chest X-rays might show developing patchy infiltrates. Management is supportive oxygen, pain control, pulmonary toilet, helping them cough and clear secretions, and sometimes mechanical ventilation if respiratory failure develops. It's a major cause of morbidity after chest trauma.
And aortic disruption, still a concern even if they survived the initial event?
Yes, definitely. Traumatic aortic disruption, usually a tear near the ligamentum arteriosum from rapid deceleration injury, is highly lethal. But some patients survive initially with a contained hematoma. They might seem surprisingly stable.
What subtle signs might you look for on X-ray or CT?
On chest X-ray, you look for indirect signs like a widened mediastinum, the space between the lungs, obliteration of the aortic knob contour, deviation of the trachea or esophagus to the right, depression of the left main stem bronchus, or fractures of the first or second ribs, which suggest a very high energy impact. However, chest X-ray can miss it. A CT angiogram, CTA, of the chest is the diagnostic study of choice now if there's suspicion. It's very sensitive and specific for identifying aortic injury. Prompt diagnosis and surgical or endovascular repair are critical.
Let's talk about the maxillofacial area and neck again in the secondary survey. Beyond the immediate airway concerns, what else?
You're doing a more detailed exam now, carefully palpating all the facial bones, orbital rims, zygomatic arches, cheekbones, maxilla, upper jaw, mandible, lower jaw, looking for instability, tenderness, or step-offs that indicate fractures. Check dental occlusion. Does their bite line up correctly? Malocclusion often means a jaw fracture.
Nerve damage, too.
Yes. Check sensation over the face, particularly areas supplied by the trigeminal nerve branches, forehead, cheek, lower jaw chin, as numbness can indicate nerve injury associated with fractures. Check extraocular movements. Account for any missing or loose teeth important to make sure they weren't aspirated.
And in the neck?
Re-examine carefully. Palpate the cervical spine posteriorly for tenderness or gaps. Check for subcutaneous emphysema, air crackling under the skin, which could indicate tracheal or esophageal injury. Look for expanding hematomas or listen for bruits, abnormal swooshing sounds over the carotid arteries, suggesting vascular injury. Penetrating neck injuries often require further investigation with CT angiography, endoscopy, or surgical exploration, depending on the location and signs.
Now, spinal cord injuries. You mentioned the high incidence and devastating consequences. Over 10,000 a year in the U.S.
That's the estimate, yeah. Primarily from motor vehicle crashes, falls, violence. And the consequences are often catastrophic tetraplegia, paraplegia, chronic pain, bladder bowel dysfunction. The lifetime medical costs, especially for a high cervical injury, are astronomical, well over $1 million.
And the association with facial injuries is significant.
Yes, remember that 10–20% association between significant maxillofacial injuries and underlying cervical spine injuries always have a high index of suspicion.
You also mentioned distinguishing neurogenic shock from hypovolemic shock. Can you remind us of the key difference?
Right, this is crucial. In neurogenic shock, caused by spinal cord injury disrupting sympathetic nervous system signals, the patient typically has hypotension, low blood pressure, but often without the expected tachycardia, fast heart rate. In fact, they might even be bradycardic, slow heart rate. And their skin is often warm and dry, not cool and clammy like in hypovolemic shock. This is because they lose vascular tone, causing vasodilation.
So treating neurogenic shock isn't just about pouring in fluids.
Correct. While some fluid is usually needed, excessive fluid administration can be harmful. Vasopressors, medications that constrict blood vessels, are often required to restore vascular tone and blood pressure in neurogenic shock.
Imaging for the spine, CT is now preferred over plain X-rays.
Yes, particularly for the cervical spine. Numerous studies have shown that plain X-rays, even multiple views, can miss a significant number of C-spine fractures that are readily apparent on CT. CT scanning provides much better visualization of the bony structures. It's become the standard of care for clearing the C-spine in high-risk trauma patients. It's vital to ensure all 7 cervical vertebrae, plus the junction with the thoracic spine, are adequately visualized.
And until the spine is definitively cleared by imaging and clinical exam.
The patient must remain in full spinal immobilization. Assume an unstable injury is present until proven otherwise. That means maintaining the rigid collar, the long spinal board, or a scoop stretcher or vacuum mattress, and head immobilizers. Preventing secondary spinal cord injury through meticulous immobilization is paramount.
Okay, moving down to the abdomen. What are the key things you're looking for in the physical exam during the secondary survey?
You're inspecting for bruising, like the Gray-Turner sign on the flank or Cullen's sign around the umbilicus, though these are late signs of retroperitoneal or intraperitoneal bleeding. Distension, abrasions, like a seatbelt sign, which raises suspicion for underlying bowel injury. You're auscultating for bowel sounds, though their absence isn't always reliable. Most importantly, you're carefully palpating all 4 quadrants for tenderness, guarding muscle tensing, or rebound tenderness, which suggests peritoneal irritation from blood or intestinal contents. Measuring abdominal girth can help track distension over time.
And the main tools for figuring out what's going on inside, the source compared diagnostic peritoneal lavage, DPL, CT, and ultrasound, FAST. DPL isn't used much now.
Not nearly as much as it used to be, no. DPL involves inserting a catheter into the abdominal cavity, infusing saline, and then draining it back out to check for blood or intestinal contents.
Why has it fallen out of favor?
Several reasons. It's invasive, carrying risks of bowel or vessel injury. It's very sensitive for detecting any intraperitoneal blood, which sometimes led to unnecessary surgeries for minor blooding. And crucially, it doesn't evaluate the retroperitoneum well, and it can miss injuries to the diaphragm. With the advent of high-quality CT and FAST, DPL is rarely performed in most major trauma centers now, though it might still have a role in very resource-limited settings or for certain unstable patients.
So CT scanning of the abdomen, what are its strengths and weaknesses?
CT is excellent. It's non-invasive, apart from IV contrast. It's great at identifying and quantifying bleeding, hemoperitoneum, diagnosing injuries to solid organs like the liver, spleen, and kidneys, often grading their severity. And it's very good at evaluating the retroperitoneum and visualizing the spine simultaneously. Well, it requires the patient to be stable enough to transport to the scanner. It involves ionizing radiation, which is a concern, especially in children or pregnant women. And while it's good for solid organs, it's historically been less sensitive for detecting injuries to hollow organs like the bowel or diaphragm, though newer multi-detector CT technology has improved this significantly.
And then there's ultrasonography, the FAST exam, focus assessment with sonography for trauma. That seems to have really taken off.
It absolutely has. FAST is now a cornerstone of initial trauma assessment in many places.
What makes it so useful?
It's rapid. A skilled operator can perform a FAST exam in under 5 minutes. It's non-invasive, uses no radiation, and it's portable. You can do it right at the bedside in the trauma bay, even while other resuscitation efforts are ongoing.
What's it primarily looking for?
Its main goal is to detect free fluid, usually assumed to be blood in dependent areas of the peritoneal cavity. Around the liver, Morrison's pouch, around the spleen, in the pelvis, and also around the heart, the pericardial view, checking for campanate. It's very sensitive for detecting even relatively small amounts of free fluid, like 100 milliliters or sometimes less.
Can it see the actual organ injuries?
Generally, no. FAST is primarily looking for the consequence of injury, free blood, not usually the specific organ laceration itself, although sometimes gross injuries are visible. It's also not good for evaluating the retroperitoneum or reliably detecting bowel injuries. And its accuracy is very dependent on the skill and experience of the operator. But as a quick, repeatable screening tool to identify patients with significant internal bleeding who might need surgery, it's incredibly valuable.
Okay, next, the genitourinary tract. What's the single most important sign to look for indicating a possible urethral injury?
Blood at the urethral meat is blood visible at the tip of the penis. That's the cardinal sign.
And remind us again, what are the absolute contraindications for trying to insert a Foley catheter if you suspect urethral injury?
If you see blood at the meatus, if there's significant scrotal or perineal hematoma, or if on rectal exam the prostate feels high-riding or boggy, you absolutely should not attempt to pass a Foley catheter.
What should be done instead?
A retrograde urethrogram, RUG, needs to be performed first. That involves injecting contrast dye into the urethra under fluoroscopy or X-ray to visualize its integrity. If the RU shows no injury, then it's safe to proceed with catheterization. If it shows a tear, a urologist needs to be consulted, and often a suprapubic catheter inserted directly into the bladder through the lower abdominal wall is required.
And for kidney injury, how is that usually detected?
Hematuria blood in the urine, either visible gross hematuria or detected on urinalysis, microscopic hematuria, is the most common indicator of renal injury. However, the degree of hematuria doesn't always correlate well with the severity of the kidney injury. Some significant injuries might have minimal hematuria.
So how are kidney injuries evaluated?
In hemodynamically stable patients with suspected renal trauma, for example, significant flank impact, associated rib fractures, hematuria, a contrast-enhanced CT scan of the abdomen and pelvis is the imaging modality of choice. It can accurately diagnose and grade renal lacerations, contusions, or vascular injuries. Unstable patients might need to go directly to the operating room.
Finally, the extremities in the secondary survey. You mentioned the potential for massive hidden blood loss earlier.
Yes, it bears repeating. Always carefully examine the extremities for signs of fracture deformity, swelling, tenderness, crepitus. Remember, a closed femur fracture can easily hide 1 to 4 liters of blood in the thigh compartments. A pelvic fracture can bleed even more into the retroperitoneum. This internal blood loss needs to be factored into the patient's overall volume status and resuscitation plan. Applying traction splints for femur fractures or pelvic binders for unstable pelvic fractures can help reduce the potential space for bleeding and provide some stability.
And there's that serious complication you touched on associated with major long bone or pelvis fractures, fat embolism syndrome.
Right, fat embolism syndrome, or FES. This is a serious, potentially life-threatening complication that typically occurs 24 to maybe 72 hours after the initial injury, most commonly associated with fractures of the femur, tibia, or pelvis.
What actually happens in FES?
It's thought that fat globules from the bone marrow of the fractured bone enter the venous circulation through torn veins at the fracture site. These fat globules travel to the lungs, where they get lodged in the pulmonary capillaries.
Like a pulmonary embolism, but with fat instead of a blood clot.
Sort of, yeah. These fat emboli cause inflammation and damage to the lung tissue, leading to impaired gas exchange and respiratory distress, similar to ARDS, acute respiratory distress syndrome. Fat globules can also travel through the lungs into the systemic circulation and affect other organs, particularly the brain, causing neurological symptoms, and the skin, causing a characteristic petechial rash.
What are the classic symptoms?
The classic triad is respiratory insufficiency, hypoxemia, shortness of breath, neurological changes, confusion, seizures, coma, and that petechial rash, tiny red or purple spots, often seen on the chest, axillae, and conjunctivae. But not all patients have all three. Tachycardia, fever, and other signs can also be present. Diagnosis is primarily clinical.
How has the management of these fractures changed to reduce risks like FES?
This has been a major shift in trauma care over the last few decades. Historically, major orthopedic injuries were often treated non-operatively or with delayed fixation. However, research clearly showed that early stabilization of major long bone fractures, particularly the femur, significantly reduces the incidence of complications like FES and ARDS.
So fixing the bones sooner is better.
Much better. Early operative fixation, ideally within the first 24-48 hours if the patient is stable enough, decreases mortality, reduces morbidity, shortens hospital stays, allows for earlier patient mobilization, which helps prevent blood clots and pneumonia, and ultimately leads to better functional outcomes. It's a key principle of modern damage control orthopedics.
Wow. So bringing this all together, what does this deep dive really mean for you, the listener? We've seen how these seemingly small details, how fast the capillary refill is, or a tiny shift in the windpipe, or bruising behind the ear can actually be massive clues to injuries that could cost someone their life.
Absolutely. It highlights just how critical that systematic, logical, and really rapid approach to trauma management is. Timely intervention based on accurately assessing and interpreting these signs, some obvious, some very subtle, can dramatically change the outcome for a patient.
It really makes you think, doesn't it? In our own lives, maybe in our work or complex situations we face. What are the subtle, vital signs we might be missing? Are there underlying issues masked by surface-level stability?
That's a great point. How can adopting this kind of meticulous, systematic lens, looking beyond the obvious, prioritizing the critical, reassessing constantly help us uncover hidden problems or risks in any complex system before they potentially become catastrophic? Something to definitely ponder.